I would like to acknowledge my teacher and my friend Dr. Rashdan for the slides. Because this is not mine actually, it's actually Dr. Rashdan's. Can you guys see the slides? Can I?
Yes, Dr. Can.
What now? Can you see?
Boleh.
Okay, so let's start. So the topic is diabetic ketoacidosis in pediatric. Okay, this is the best approach up till 2020. So it's not up. So it's up to the up till 2020. So the outlines, I'm going to talk about understanding diabetes and DKA, management of DKA in pediatrics, and how it differs from adults. And so a bit of case study for discussion. So this is a very busy slide, but it's very important. So this is to make you understand the pathophysiology of diabetes type 1 in the pathophysiology of diabetes type 1. So it's usually occurred in people with genetic predisposition to diabetes. However, it's usually triggered by immunological response towards infection. Okay, so basically, infectious or environmental stimulus triggers autoimmune attack on pancreatic beta cell, and then it leads to destruction of beta cells, and finally, near absolute endogenous insulin deficiency due to beta cell disruption, and finally, requiring of exogenous insulin supply. If you look at the graph, to understand the graph, on the right side is HbA1c, on the left side is beta cell mass. So you only need about 20 or 10, 15 to 20% of your beta cell mass to actually to live normally. Okay, as long as you got more than 20% of beta cell mass, you can actually produce enough insulin for your daily requirement. Okay, this same goes with all your other organs. For example, like you only need about 20% of 10% of one kidney for you to live normally, okay, to function normally. And same goes with your liver. You only need about 5% of your liver mass. Not brain lah. Brain and heart is different. Okay, if you lost half of your brain, then you're gonna so do heart. But most of other organs are actually can function very well with minimum. So Allah had been giving us a lot of extras. So that's why we have to be thankful. Okay, if you look at this, most of the time, diabetes, the type 1 diabetes can the physiological changes or the pathophysiology of type 1 diabetes already occurred up to 8 years before diagnosis. Okay, in those with genetic predisposition, for example, those with HLA-B27, these are the high risk group where some particular immune or infection can trigger immunological response against the beta cell of pancreas. So hopefully you can understand the graph. So usually by the time of diagnosis, at year 0 of diagnosis, usually the beta cell mass will be around 15 to 20%. Okay, until then they will become diabetes and require insulin. Okay, based on DICARE 2006 to 2009, DICARE is the diabetes registry. So DKA is the most common presentation of type 1 diabetes. So most type 1 diabetes initially presented with DKA. Okay, it's more common in younger children, less than 4 years old, and from those with lower socioeconomic groups. And in established patients, in patients with diabetes, risk of decay is about 1 to 10% per year. Okay, about 10%, more or less 1 to 10% of children with diabetes presented with DKA every year. The pathophysiology of DKA, okay, so basically absolute or relative deficiency of insulin, okay. with a combination effect of counter-regulatory hormones. Okay, what are the counter-regulatory hormones? These are catecholamines, glucagon, cortisol, and growth hormone. Basically, in your body, you got the main type of peptide hormone or and also thyroid hormone is you've got your diabetes, your insulin-like hormone, and also your anti-insulin hormone. So these are the anti-insulin hormone, which the effect is actually to increase the level of glucose in the blood. So this can occur in undiagnosed type 1 DM, in those type 1 DM who did not comply with the treatment, or those who's got an exaggerated response of counter-regulatory insulin hormone. Okay. For example, like those with sepsis, trauma, or GI, diarrhea and vomiting illness. So pathophysiology of DKA. So we've got absolute insulin deficiency or stress infection or insufficient insulin intake leads to counter-regulatory hormone increase in secretion of counter-regulatory hormones. And finally, this is the effect. You've got the lipolysis, increased glycogenolysis, gluconeogenesis, and reduced glucose utilization, and then proteolysis, reduced protein synthesis, and so on. So this is a basic homeostasis, glucose homeostasis. Okay. Okay, so basically DKA is because due to balance between insulin and counter-regulatory hormones, so it leads to hyperglycemia, acidosis, and also ketosis. Okay, why? You have to understand, without insulin, you will not be able to utilize the glucose inside your blood. So just imagine you've got a lot of glucose inside your blood, okay, because you don't have insulin. So a lot of glucose, and for example, you've got a child who are sick, kan, children who are sick. So what happen is they produce a lot of they've got cortisol, they've got all this growth hormone, thyroid hormone, which actually leads to a lot of gluconeogenesis and a lot of glucose in the blood. But this glucose cannot be utilized. So what happened? You are in the state of starvation. So you got tissue starvation because without insulin, all these glucose are useless. Okay, so this glucose will remain in the blood, cannot be pumped out into the tissue and be utilized, be metabolized. So what happens is your tissue are hungry of energy, so which leads to ketosis. Okay, so your body try to compensate. They need fuel, so the tissue, especially muscle and also liver, start to produce a lot of ketone, and this ketone will accumulate and leads to acidosis. Okay. Okay, again, this is the simplified pathophysiology. Okay, so when you got fever, okay, it leads to increase in metabolism and increase in secretion of your stress hormone. Okay, because when you got fever, your body need a lot of energy. Okay, what happen in stress hormone? When there's a lot of stress hormone, so you've got increase in fatty acid, increase in ketone bodies, and increase in gluconeogenesis, because you are ready to fight and flight. Okay. So what are the goal of treatment in DKA? So number one is dehydration. You have to remember these keywords. Okay. When you're managing a DKA child, okay, your aim of treatment is number one, correct the dehydration. Number two, correct the acidosis. Number three is reverse ketosis and prevent further ketonemia. Number four is slowly, okay, remember, slowly correct hyperosmolality. Okay, what are the formula for osmolality? Anyone? How to calculate serum osmolality? Anyone? The formula is glucose plus what? Plus urea plus sodium. Okay, and plus minus potassium. So basically glucose contribute to osmolality. So if you've got a lot of glucose in the blood, it leads to hyperosmolality. So you have to correct this hyperosmolality. Lemak, jap. Huh? So it's a lecture jap. Okay. Okay. Sorry about visitors. Anyway, so and then the next one is to restore blood glucose to near normal. And number 3 is to monitor for complications of DKA and its treatment. And finally, to identify and treat any precipitating event. So remember, most of the time, DKA is precipitated by an event. Okay, even though you may not be able to identify the event, but usually it's precipitated by event. Event can be any stress. It can be physical stress, emotional stress, or it can be infection. Okay. Okay, so management of DKA in pediatrics. Okay, this is based on the guideline. Okay, so the onset of type 1 DM, uh, usually DKA presented at onset lah. In Malaysia, about 60% of children presented initially with DKA. So what are the risk factors? Okay, young age, less than 2 years old, delayed diagnosis, low socioeconomic, and countries with low prevalence. So Malaysia is considered countries with low prevalence because DM type 1 is more common in the Western countries, especially in the Scandinavian. In Scandinavian, the prevalence is about 10 to 20%. So about 10 to 20% of children has type 1 DM. In Malaysia, it's less than 1%. I think it's even less than that. I think about maybe 0. I can remember. But I think about 0.5% or even less. Okay, it's quite rare in Malaysia, but in some countries like Japan or in Scandinavian, there's a lot of children with DKA, with type 1 DM. So management in ED. So basically, the principle of management include in emergency is acute resuscitation care, immediate and continuous evaluation, and total DKA care. So these involve the management of all the 6 or 7 yang I've mentioned just now, which is hydration, treating dehydration, electrolyte. Okay, nanti ada the slides, okay? I'll go to that later lah. Let's look at the chemical and biochemical features. So clinical features include nausea, vomiting, abdominal pain, dehydration. Abdominal pain, nausea, vomiting is usually because of shock. Okay, DKA can lead to shock. It's a hypovolemic shock because of hypoosmolality leading to hyperconcentration of blood. Okay, and then dehydration, altered consciousness, tachycardia, tachypnea, caused by breathing to acidosis, acetone smell, breath, and also classical hyperglycemia symptoms such as polyuria, polydipsia, so on. Okay, biochemical, to diagnose, blood glucose must be more than 11, kpH less than 7.3, bicarb less than 15, and there must be ketonemia. Okay, ketonemia means serum ketone more than 3 millimole per liter or ketonuria more than 2 plus. So the severity can be divided into mild, moderate, severe. Mild, pH less than 7.3 with bicarb less than 15. Moderate, pH less than 7.2, bicarb less than 10. And severe, pH less than 7.1 with bicarb less than 5. Okay, 3 most useful signs for predicting more than 5% dehydration. Okay, remember, okay, these are the signs of more than 5% dehydration because in diabetes, the first step is to determine how severe is the dehydration. And usually in DKA, you need to have a slightly higher threshold to treat. For example, if based on your assessment, the child has like 10% dehydration, usually you goes down to 7.5. So you treat them according to 7.5% dehydration, even though the assessment is about 10%. Same goes if you think the child is moderate, so you can slightly reduce the correction because because later on you want to be very precautious in treating dehydration, because you don't want to you don't want to cause hyponatremia. Okay, so you can look at the capillary fill time, abnormal skin turgor, respiratory pattern. Okay, ada visible sign like such as mucosa lah. Look at mucosa, tears, pulses and extremities. So shock, again, if there's shock, then you need to treat lah. Kalau anything shock, it has to be at least 10%. Okay, but in outside of DKA, shock means at least 12.5%. Tapi in DKA, shock means 10%. But it's very rare lah in DKA. Okay, acute resuscitation, immediate management is fluid, potassium or electrolyte, insulin and plus minus bicarbonate. Okay, and definitely you need continuous evaluation. In patient with DKA, it has to be managed in ICU. Mortality is very high, and morbidity is also very high. You may not lose the child, but you end up a child with vegetative state because of cerebral edema. Okay, so as usual, you have to assess the ABCD, airway, breathing, circulation, and also disability. Make sure you've got good venous access. Measure the blood glucose, the blood, especially blood ketones, electrolytes, blood gases, and fluid blood count on arrival. Okay, you have to monitor ECG. You have to monitor continuous cardiac monitoring. And then if need be, usually if the child, definitely you won't allow the child to walk around, so you need to insert CBD, and then start antibiotic if the child got fever. Okay, and then you need to weigh the child. Okay, use the dry weight. This is the dry weight, and use this for fluid calculation. Remember, start fluid replacement before insulin. Okay, fluid replacement before insulin. In HSS, you need more fluid than in DKA. So in HHS, you give more fluid in DKA. Remember that. So in DKA, that's why in DKA, usually assessment of dehydration, you you are more lenient you are more stingy in your fluid in DKA compared to in HSS. Okay, so start your fluid depending on the status dehydration. Okay, if severe volume depletion, just go 7 to 10%. Don't go beyond 10%. Except in compensated shock. In compensated shock, give boluses and then continue with managing dehydration. Okay, again, compensated shock, give bolus, and then continue with 7 dehydration. Okay, fluid therapy subsequent, just continue with your correction and also maintenance. Okay, maintenance, remember, you don't give correction over short period. You don't give over 12 hours or 6 hours or even 24 hours. Usually we correct over 40 hours. The rule is any child who presented with chronic symptoms, you have to treat chronically. Okay, if the child ill for 2 days, then give correction over 2 days. If 3 days, give correction over 3 days. Because you don't want to drop the sodium too much. Okay, because this leads to cerebral edema. Okay, boluses should not be included as part of total fluid requirement. So if you need to give bolus, there have to be something extra. Okay, this is other thing. It is a bit too detailed lah, but anyway, it's all about fluid. Okay. Okay, next is potassium. Okay, this is the second most important, first most important electrolyte. Okay, in a patient with before you start insulin, you have to establish the level of potassium. At least you need an ECG, at least. If you don't have blood gases or if you don't have RP to measure the potassium, you have to have ECG, okay? Okay, so if no more kalemia, you don't start potassium straight away, okay? You start potassium after the fluid or after the first fluid. If patient is hypokalemia, you start straight away, okay? If patient normokalemia, remember, if normokalemia, you start potassium after fluid. You remember, kalau OBA, definitely this can come out. For example, we can ask you, what is the initial treatment? So definitely the initial treatment in DKA is fluid, followed by potassium, provided the potassium is normal. If the initial potassium is low, then you have to give potassium together with the initial fluid. Okay. If the potassium is hyperkalemia, so start potassium after the urine output documented. So you can delay the potassium later. Okay. Remember, must not exceed 0.5 millimole per kilo per hour. Okay, except in ICU setting. Remember, this is the safe concentration. You can only place 1.5 gram potassium in 500 ml pint in a pint. Okay, don't go beyond that, except in ICU setting. Okay, always maximum just put 1.5 gram per pint. Okay, second is insulin. Okay, after the fluid, start insulin. Okay, insulin will only start at 0.05 to 0.1 unit per kilo per hour. Remember, start very slow, start slow. You don't need high insulin, but you need to maintain the presence of insulin is required to prevent ketone production, and also to convert the ketone to glucose, and also to pump in glucose into cell. Okay, so you don't need much insulin more, but you need to always have insulin, even though the glucose is normalizing. But as long as there's ketone in the blood and there's acidosis in the blood, you need the insulin at its lowest dose. Okay. In some children, especially those yang newly diagnosed, they are very sensitive to insulin. So you need to use very low dose. If not, they turn out to become hypo. Remember, hypoglycemia is bad also. If you got hyponatremia on top of hypoglycemia, will definitely get cerebral edema. Okay. So the aim of insulin is make sure the pH more than 7. You need to maintain the insulin infusion until pH more than 7.3, bicarb more than 15, ketone less than 1. Okay, ketone less than 1. And also the anion gap normalized. The next is bicarb. Never give bicarb. Remember, never give bicarb. Even though the site is here, but never give bicarb except ordered by specialist. Or the pH is less than 6.9. It's too acidosis. Basically, in the world, there's not many condition. Usually you won't see someone alive with pH less than 7, except in DKA. Okay, only a child with DKA can remain alive with pH less than 7. Adult, you got pH 7, then you know the patient is going to die lah. Adult. Children, babies can stand up to 7. Newborn 7, 6.9, 6.8. Sometimes they can still survive. But generally, children, 6.97 is the cutoff point. Usually less than that, they will die. Adult, 7.17 usually die lah. But in DKA, you can see a child with DKA with pH 6.9 walking. Okay. So continuous evaluation, including hourly blood glucose, monitor vital sign, neurological observation. Fluid input output has to be at least hourly. And then RBS, you may serum blood glucose 2 hourly, blood gas maybe 2 hourly, ketone, because it's quite expensive, you can do like 2 hourly or 3 hourly. Okay. I think this is a bit too much, but in general, this is about saline lah. What fluid you should give is saline. Okay, give saline without dextrose. Remember, you give saline without dextrose, unless once the blood glucose reducing less than 16 or less than 15, then you may need to add up D5. Okay. Okay, fluid management, insulin therapy, electrolyte adjustment, continuous monitoring, and transition to basal bolus. This is after patient out of DKA. And finally, DM counseling, education, and care and follow-up. But these are actually beyond the scope today. I'm going to discuss only on the acute management. Okay. you have to always monitor the subtle sign of cerebral edema. Okay, you have to monitor the sodium level and also subtle sign of cerebral edema. Monitor the conscious level closely. These are the first sign of cerebral edema. If you see the child become more obtunded, less responsive, then you have to be cautious. Stop the drip, monitor the sodium, check the pupil. That's the least you can do. Check the pupil, do fundoscope, look for any papilloedema, and then do CT scan. Okay, because most mortality of DKA is from cerebral edema lah, besides severe acidosis. But usually cerebral edema are the reason of death among patients with DKA. Okay, what happen is you've got acidosis, hypocapnia. Because when you've got acidosis, you've got hypocapnia. So your body compensating by get rid of your carbon dioxide from your blood to the lung. This leads to vasoconstriction and reduce cerebral blood flow. Okay, and then dehydration further reduce cerebral blood flow, and reduced cerebral blood flow leads to cerebral injury, and finally leads to cytotoxic edema. Okay, and on top of that, with hyperosmolality because of low sodium and low glucose because of your insulin treatment, because now you are reducing the glucose in the blood, which contribute to the osmolality. On top of that, because of when the glucose enter into the tissue via the glucose sodium pump, so it will actually reduce your sodium as well. So this contribute to further reduction in osmolality. So idiogenic intracellular osmol, blah, blah, blah. Brain hypertonicity due to rapid correction and water flow leading to cerebral edema. Rehydration, hyperfusion injury leads to vasogenic edema. So cerebral edema, there's a lot of type. Okay, there's a lot of type of cerebral edema. For example, those with accident and those MVA, they can develop cerebral edema. Those with DKA can develop cerebral edema. Those with overtreatment fluid SIDH, these can also develop cerebral edema because but the pathology is different. It can be cytotoxic edema, vasogenic edema, cerebral also osmotic lah because of also osmotic injury. But in DKA, all of these can contribute. Okay, cerebral injury leads to cytotoxic edema, rapid correction, hyponatremia leads to cerebral edema because of osmolality, and also reperfusion injury leads to vasogenic edema. So how to diagnose cerebral edema? You have abnormal motor or verbal response to pain, which is conscious level. Okay, decorticate, this is the late phase. Cranial nerve palsy, also quite late. Abnormal neurogenic respiratory pattern, this is the chimney stop respiration, this is also late. The first sign is abnormal responses, conscious level, that is the most important. Okay, major criteria, altered conscious level. Okay, and then subsequently you get coning, and this leads to the Cushing triad. Okay, you've got the bradycardia with hypertension. Okay, minor criteria is vomiting, headache, lethargy, but this might be difficult, especially in a comatose DKA children. Okay, so management, prop up patient 30-degree. Okay, reduce the rate of fluid administration by 1/3. Remember, reduce the fluid. Okay, give IV mannitol or hypertonic saline. Okay, this is, I think you don't need to know this. But definitely, if the conscious level reducing, you need to intubate. So how DKA in children differs from adults? In children, mortality is very high. Remember, in adult, okay, HHS has a higher mortality compared to DKA. In fact, in type 2 DM, develop DKA first, then if not treated, DKA will further progress to HSS. Okay, but in pediatric DKA, rarely you got HSS in pediatric except in type 2 DM. But DKA in pediatric has a very high mortality. Okay, and then precipitating factors, infection. Okay, even though mortality rate is 5% in adult, tapi DKA in adult is very rare because they got HSS kan. But if DKA in pediatric is quite common. Okay, precipitating factors, infection, mistherapy. This is in adult lah. Okay, this is in adult. Okay, diagnostic criteria is quite similar lah, sama je dengan adult pediatric. Okay, severe DKA, bicarb less than 5, blood ketone more than 6, venous pH less than 7.1. These are actually the prognostic factors. Okay, you've got this, usually this is bad prognosis. Okay, this just to recap. So the first hour is fluid management. Fluid management, number one. And then after the fluid, after you give the first initial volume expander, you give the insulin. Okay, step 2 insulin. So step one is fluid. Step 2 is insulin. And then step 3, the assessment. And finally, just monitor lah after you give insulin. Then that's the two main treatment lah, fluid and insulin. The rest are actually monitoring and treat whatever need treated. For example, potassium ke sodium, yang tu goes after insulin and also fluid. Remember no bolus insulin, no bolus insulin. You only got bolus fluid. Okay, remember potassium, you have to monitor potassium closely. Most of the time, you need to give potassium. Okay, the rest is just monitor ketone and so on. Okay. Okay, when you can shift from DKA, definitely nail by mouth. Nail by mouth, hourly. Usually we use sliding scale, so monitor blood glucose hourly, and you adjust the insulin infusion based on the hourly blood glucose monitoring. Okay, okay, I think that's all actually. So when to change infusion to vessel bolus? Number one, you have to make sure there's no more ketonemia, there's no more acidosis, especially acidosis. Okay, once there's no more acidosis, the pH turns normal, more than 7.3 at least, then you can start to shift from infusion to vessel bolus. But you need to overlap for 1 hour at least. Okay, that's all. Any questions? Oh, you dekat hall kan? So anyone want to ask question, you can ask. Kat rumah. Anyway, so any questions? Kalau tak ada, then kita boleh ni lah. Oh, will type 1 DM eventually cause hepatomegaly? Not really. Okay. Except remember, the current trend, because of the current diet and sedentary lifestyle, okay, even though in the past we say type 1 DM, they are usually very thin, but nowadays we get a lot of patient also got type 1 DM with metabolic syndrome. So you can get type 1 DM with fatty liver. Okay, those with fatty liver can present with hepatomegaly, but usually no. Okay, when the answer is no, except in cases where the patient is on high dose insulin and presented like type 2 DM. Okay, any other questions? Okay, kalau tak ada, then kita boleh stop. So all the best in your final pro soon, in your end of block. Okay, tu boleh tanggung dengan tasbih. Kafarat and Syakratullah. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, doctor.
Thank you, doctor.